Friends, today I'll be talking about the brachial plexus contouring. This is, I think, one of the most critical organ to contour and difficult one also. My many of the junior colleagues are doing brachial plexus contouring, but I was initially struggling to contour the brachial plexus. Before doing the brachial plexus, we should understand the anatomy that brachial plexus is formed by the contributed by the C5, C6, C7, C8, T1 nerve roots. So initially the vertebral foramen release these nerve roots and this nerve root forms the trunk. So according to the latest RTOG guidelines, RTOG guidelines says that you have to focus on the roots and the trunk basically because the trunk forms the cord and then as on goes up. So if we see the brachial plexus, we must not forget about this figure that the brachial plexus is having release from the intervertebral foramen between the two muscles of scalene anterior and scalene medius. Scalene anterior has a narrow end, has a narrow end and narrow insertion, but middle part it is thick. So in between the two scalenus anterior and scalenus medius muscle, the nerve roots really of brachial plexus comes out and as well as the subclavian artery. So this muscle basically by the originate from the anterior tubercle, the anterior scalene muscle, and from posterior tubercle, the scalenus medius muscles. So this scalenus anterior release from anterior tubercle of transverse vertebra C3, C6, and scalenus medius uh, comes from the posterior tubercle of which we can see here. The scalenus medius from posterior tubercle of transverse process of C2 to C7 vertebra. And we are least bothered about the scalenus posterior muscle. And scalenus anterior is inserted in the first rib and the scalenus medius inserted on the upper surface of a first rib behind the subclavian artery. This is actually the basic anatomy which if we remember this thing, we can really go to the for brachial plexus contouring if we understand this thing. So if we see here, uh, if you can go through this thing, you can see how this nerves root form the cord and then root, trunk, and a cord, and ultimately passing under the clavicle and supply this thing. So when we treat the thoracic inlet tumor or oropharyngeal tube cancers or particularly lung cancer, those who are on the apex of the lung, the Pencross tumor, then this organ is very, very important. And in the current scenario of SBRT, stereotactic body radiotherapy, when we give a high dose of a radiation, almost 10 grain 5 fraction, we treat a lung cancer, so that this is become very important to protect it because in conventional fractionation, almost 60 gray there is no problem, but in the high dose radiotherapy that you have to check it by it should check and tell your physicist that the dose should not be received to these nerve roots more than between 20 to 25 gray. because beyond that, the brachial plexopathy is bound to occur. So I've told you the regarding this thing, scalenus relation of this thing. This figure is very important that you see here the scalenus anterior muscle, scalenus medius, and this intervertebral foramen here. Between this, the brachial plexus lies. So how we do a contouring? We see here. What we do it, you count the vertebra. You see here the C2 vertebra, C3, C4. So in between the C4 and C5, the nerve roots comes out, and C4, C4, C5, C6, C7. There is no C8 vertebra and then T1. So we are focused here from the one, two, three, four, fourth vertebra to T1 vertebra in level, so that we can do a contouring in between this vertebra, considering this intervertebral foramen from C4, C5 to T1, T2. So if we see here C2, C3, C4, the C4 intervertebral foramen. Now you start contouring. Take a 5 millimeter of brush, and then just mark here. You see here, because in I told you in the upper cuts, this scalenus interior have a very narrow end, and then the middle portion it is thickened, and the lower portion it is again thinning. So we basically go towards the, this is the jugular vein. So initial portion you are see towards the jugular vein also, and a scalenus medius, the anterior to the scalenus medius muscle. Now you can identify here the gap between the scalenus anterior and scalenus medius. And now you are clearly you can identify here the scalenus medius muscle. And then I told you that the muscle of a scalenus interior is thin. So when you won't be able to, you are not able to recognize the scalenus anterior muscle, then you track the scalenus medius muscle, and just anterior to it and the gap you should fill with a 5 millimeter brush, that you are hitting the brachial plexus nerve root. Now you are able to clearly differentiate between this scalenus anterior muscle here and scalenus medius muscle here. If you can go to track this scalenus anterior muscle in the lower section, it's getting now this is scalenus anterior, this is scalenus interior, scalenus anterior, scalenus medius, or ultimately it goes and insert on the first rib here. You can track down here. So in the lower section, you start seeing the subclavian artery, You fill the gap here, fill the gap here. Scalenus medius is very, very clearly obviously visible here. Now you can see here scalenus anterior and medius muscle. Fill the gap here. This I mean, maybe remove this thing, I think. Now you can see here where are you reaching. C2, C3, C4, C5, C6, C7, and now T1. You are reaching T1. So you have seen here. Now you can see here of this the so my system is not allowing to put a mark here, but otherwise I would have put a mark here C2, C3, C4 on the mark on the C4 vertebra and C2, C3, C4, C5, C6, C7, T1 vertebra, T1, T2 junction. So now you have contoured it. See how much percentage you have covered. Almost 81% of brachial plexus is contoured here, and ultimately you uh, find it here is something V-like structure if you contour both sides of brachial plexus. But usually at a one time you contour one brachial plexus, usually because either if you are treating a lung cancer of here, a tumor, and you are protecting the brachial plexus of this side, then usually contour the right brachial plexus, or sometimes in the left brachial plexus, or sometimes in the orothoracic inlet tumor you contour both brachial plexus. So this is a I think most of you will be aware also. So how can you contour the brachial plexus? And so I told also you regarding the it is one of the most difficult organ to contour because you have to find out the anatomy of subclavian artery, jugular vein. You can see here jugular vein at the cricoid cartilage. That means cricoid cartilage lie at the level of C6 vertebra, so that you can go. Obviously, it is slight section is C6. You can also see the thyroid on the side, and initial portion you initially you usually in initially you encounter the jugular vein, and in the lower section of a slice you encounter the subclavian artery. So the where is subclavian, you can easily identify the subclavian artery here. This is this is a subclavian artery, and then we must remember the vein that is means the internal jugular vein, V subclavian artery, and posterior to subclavian artery is brachial plexus, that is nerve vein. So with this, we finish the brachial plexus contouring, and we'll be meeting you in the some different organs contouring somewhere. So why it is important of brachial plexus in order to protect the brachial plexopathy? Actually, the C8, T1, and then ulnar nerve impairment, uh, numbness, tingling, weakness, these all happens in case if you do not protect these organs during the heavy dose of radiotherapy, that is stereotactic body radiotherapy, when you are planning for a head and neck cancer or a thoracic inlet tumor or a lung cancer. So this is the importance of it. Thank you very much.